here.
Perfect. Uh, I'm Dr. Rakesh Mahajan. I'm presently Chairman, and HOD Department of Orthopaedics at BLK Super Specialty with more than 30 years of experience. I started my orthopedic practice in post-graduation in 1986-87. So I'm now a veteran, I would say. No, that time we used to have general orthopedic surgeons, and finishing my senior residency and then teaming up with the different centers and all these, we didn't have many specialties, subspecialties like sports specialty, joint replacement. Now, for the joint replacement, we have different joint replacements. Means hip joint replacement specialist, knee joint replacement specialist, shoulder joint replacement specialist. How the things have progressed over the years. Uh, uh, I would say in 90s, the sports arthroscopy was very primitive. We used to see with the eye. We used to put the lens and we used to see with the eye, naked eye. Now we have very high resolution cameras and high resolution monitors where everything is so magnified, and there over the decades there has been refinement. Now, even coming to the orthopedic joint replacement, especially hip replacement, I initially had a very lot of interest in the hip replacements and hip pathologies. Hip pathology is something which does not let the patient to uh, perform well. Patient can carry on with knee arthritis or with spine spondylitis, degenerative spine, or but not with hip. Hip is not, I mean, it never allows the patient to move freely. Once it is damaged, you have a lot of problem in your locomotion. So coming to a special topic of complex total hip arthroplasty. Complex, one is the primary total hip arthroplasty, whereas the common indication is the simple arthritis, osteoarthritis of the hip. Although in India, primary osteoarthritis of the hip is comparatively lesser incident, but in Western countries and in African countries and the CI countries, the incidence is quite high. So, number of cases come to us, and we have been gaining experience from different uh, uh, countries, and over the years I'm operating more than 400 hips per year, and quite a lot percent is complex total hip arthroplasty. And why we say complex total hip arthroplasty? There are certain conditions in the hip which lead to complex hip arthroplasty. Simple hip arthroplasty is primary hip arthroplasty is a very straightforward surgery, and mm, one can finish in 45 minutes, but not the complex hip arthroplasties or revision hip arthroplasties. They take a lot of time. They can be as long as 2 hours or 2.5 hours surgery timing. So coming to the various indications where we see need for complex hip arthroplasty, one can see after trauma, the trauma can lead to severe acetabular fractures, and severe acetabular fractures can be stable or unstable, and there are different types of acetabular fractures, and acetabular fractures are not that easy to maintain, and they may malunite, they may not unite. Then it can further lead to established traumatic arthritis because of acetabular fractures, which again includes part where one can see the avascular necrosis of the femoral head. When the vascularity of the femoral head, which comes from the profunda femoris artery, the capsular vessels, majority comes from there, where they can get damaged and they can get thrombosed and can cause loss of blood supply to the femoral head and the damage to the cartilage and leading to severe arthritis. Then it can have happen after failed fractures. Failed fractures can be because of the neck femur, different type of, especially the subcapital fractures. where the vascularity is always uh, guarded, they can lead to high. They have a high incidence of avascular necrosis. Fracture can unite, but it can lead to avascular necrosis. Then there can be IT fractures, failed IT fractures. Well, I will show few cases where we come across these conditions. The fracture has united, but the neck has foreshortened because of the fracture. Means the neck has become smaller in length, and it has led to collapse of the neck, and there is a varus or valgus deformity which leads to secondary traumatic arthritis. Then the other common indications is seen in young patients, symptomatic irreparable cartilage loss. Now, this can happen in young patients, players, different sports activities like basketball player or I mean football, hockey. So many active sports can lead to uh, cartilage damage or labral damage, which can progress to different types of arthritis, which can be cam type or pincer type. These are called FAI, femoroacetabular impingement, and then the cartilage loss, which progresses to lead to arthritis. Then there can be extensive bone loss or acetabular erosion because of trauma, because of sports activity, because of younger people are now more active in their gyms or sports. These can all lead to different types of bony loss or acetabular erosions. Then there can be femoral head collapse because of these various activities. And in young people, we also see the developmental dysplasia of the hip. What is development dysplasia of the hip means? Earlier we used to term it as congenital dislocation of the hip. Now it is developmental dysplasia of the hip. When the child is born with the dislocation of the hip, and then it can undetected or difficult to maintain can lead to developmental dysplasia of the hip, where the head is outside the uh, acetabulum, and there is poor development of the acetabulum, but the head keeps on growing and becomes mega head, which can lead to inappropriate uh, head and acetabular geometry congruity. The other indications are normally seen in complex are after previous surgeries. Previous surgeries can lead to even primary THR can lead to one can see aseptic loosening. Aseptic loosening means over the years they one observes uh, loosening of the implant at the implant bone cement interface, especially in cemented type. But in uncemented type, it can be because of various shearing forces which can lead to bony erosion and loosening. So one has to observe in the X-ray, in the Maverick MRI, or in the CT scan whether it is septic loosening of the acetabular cup or the stem. If there is acetabular loosening of the stem, I mean the loosening of the stem, then we can see the submission means the stem starts collapsing. These can be seen in older patients where the bone becomes weak, osteoporotic bones, which can lead to collapse of the stem. Then there, after previous surgery, even after primary THR surgery, one can see dislocations. And mind it, a well-fit primary THR can carry on for 30 years or 35 years uncemented. But if the geometry, I mean the version is not good, then the hip is going to dislocate within 3 months. About 90% of incidence is 90% of the dislocations occur in first 3 months of the primary THR. This means there is some problem with the geometry, with the congruity, or with the person. There can be instability because of the weak abductors. We have the gluteus medius and minimus as the main abductors of the hip, which can be weak because initially because of post polio or because of some other neurological conditions which can, or some damage or some infection which can cause instability leading to dislocation of the hip. In those cases, if there is abductor mechanism instability, we think of the other three things. Like we go for a tripolar or MDR hips are available, which are very good for instability, where the motion of the hip takes place at two planes, so that the chances of dislocation or instability are minimized. And however, the range of hip definitely becomes lesser as compared to the primary THR, but it gives definitely the stability to the hip. Then osteolysis can be observed on the femoral stem or the acetabular cup. Then the previous implants can show fracture because of a trivial fall or because of some other reason, or it can get infected, especially in diabetic patients where the high risk of infection is very, and the incidence is very high in diabetic cases. Or there can be old retained hardware which can lead to a pathological fractures. These are called stress fractures because of old hardwares or removal of the old hardware, which can cause a stress fracture, and patient can go for needs complex revision. Other complex cases include there is a pre-existing hip arthritis which can be say Tom Smith hip. Say patient had a infection of the hip, septic hip in the childhood, which has not grown. And see, once the septic sepsis occurs, there can be osteolysis, osteonecrosis of the femoral head. There can be complex deformity with no version. Patient, the hip can be in retroversion or antiversion. In any condition, there can be tight adductors and all those complex cases which are, I mean, one has to have the experience, one have to nick to how to solve it. So it's a very complex maths. Complex hip replacement is not straightforward. One has to, I mean, like Einstein, one has to think which should be the best combination and which should be the best approach to approach a complex hip replacement. Then there can patient can present with severe deformities or limited motion, whereas patient can come can in enclosed hips. Patient have will have uh, I mean totally enclosed hips. How to go for that? These are all complex hips. In say I would say means the hip is totally fused, enclosed, totally bony
Umida,
enclosed.
umida.
Right?
Uminko.
Then we have previous unsuccessful treatments which can where we need these. There can be significant muscle weakness. So these are the, again I am coming to the surgical planning of the complex hip. Surgical planning, I told you, take your time, don't hurry, and plan for everything. Think out of the blue, how to manage it, how to see. Patient can come with simple pain. Simple pain is a symptom. If patient says, do my THR, I will not do it because identification of the problem is very important. Whether there is instability or there is, I mean, leg length discrepancy which is troubling the patient and causing a pressure on the spine, these have to be considered. Again, coming to the fact that dysplastic hip, avascular necrosis, and post-traumatic arthritis are the most common indications for complex hip replacements. So, planning necessitates a thorough investigation of the cause or failure. Physical examination includes assessing the abductor function. I mean, the abductors have to be there. If the patient is lacking no abductors, then I'm telling you, or if they are weak, then we have the special hip replacement called the tripolar hip replacement, or we call it MDR, which has three parts. I mean, head, and liners and two liners and then the acetabular shell. So the motion takes place in two planes with the advantage that the stability of the hip is there in spite the range of movement is decreased, but that doesn't matter. Patient is looking for pain free hip and stability. And then in the physical examination you look for leg length discrepancy. Again, coming to you, for leg length discrepancy, you always get the long films, and you can, on the physical examination, you go for the measurement of the length and see up to 2 centimeter we are able to achieve with the implants. 2 centimeter length, within 2 centimeter we can achieve gain the length, not beyond that. If you're looking for, if you're telling the patient I will lengthen your shortening, but be careful, not more than 2 centimeter. If no, if it is more, then we give always a shoe raise. Rest of the discrepancy is maintained with the help of the shoe raise. Coming to the radiographs, we get AP, pelvis, and Judith views. What are looking in the Judith views? We are the, these are the obturator views. It can be, we look for the acetabular shell or acetabular roof, whether it is maintained or not, right? And if there is any uh, doubt, we could go for CT scan. We go for 3D CT reconstruction, 3D CT reconstruction to see how much deficit is there in the femoral stem or the acetabular cup, and we need reconstruction accordingly. Say if the posterior wall or posterior column is deficit, we have to reconstruct that posterior column or the posterior wall. And if the anterior wall or anterior uh, column is missing, then we go prepare everything accordingly. And if the dome or the roof is not there, we proceed accordingly. So these are whereas the we have the various implant options. We have jumbo cups even up to 65 65 mm jumbo cups are available in case there is stability of the posterior column or posterior wall and the interior column. See, the cup sits on the two walls, so the stability has to be maintained through the interior wall and the posterior wall, and not on the superior wall. There's nothing like superior wall. And at 6 o'clock we have the TAL, the transarticular ligament, which is our guide. The for the teardrop, so that the position of the acetabulum is, inclination of the acetabulum is maintained. Once the trans acetabular ligament is maintained, then we have high hip center cups. We have oblong bilobed offset cups. Impaction. We need impaction grafting or structural grafting. We have metal augments. We have 3D printed. Now we have 3D printed custom implants where the patient anatomy is entirely different. If we see it on the CT scan, 3D CT, then we can get 3D printed custom implants. These are especially needed when patient has developed the deformity of the, I mean, arthritis after some problem in the childhood. With the growth, with the age, the cup or the stem has not developed. Sometimes we find the stem, the internal medullary canal is less than 6 mm. So what to do? We get 3D printed customized implants. Now various companies are available. We send them and we get the special implants made for the patient, and we achieve the best results. This is the model of the 3D printed metal model. So if you see, there is no anterior wall; it's totally missing. This is a rough idea of how we have different choices of the implants, the indication for the implants. Paprosky classification is roughly followed. We now have AOS classification, but these are hardly used. These are only a simple guide. Say we have different 1A, 2A, and 3A, B. In 1A, the the bone loss is minimum. Simple hemispherical cups or screws are available. Then 2A, we need metal implant augments to put it on the posterior wall deficit or the anterior wall deficit. Mostly it is the posterior wall deficit which is the troubling thing. And then the 2B is there. So many we have for different, the hardware should be available. It is not that like if we open up and we see we need this and it is not available. We have to tell to the patient, we take your time, we take our time, we take may 4 days, 5 days, we discuss it multiple times. We take the bone model, the pelvis bone model, and we'll mark it with the 3D films where the deficit and how to reconstruct it. And now, because with the help of the AI, we are able to judge where we'll see it. With the help of AI, we are able to imagine how the sitting will of the implant will be there. These are the various metallic cups. These are the titanium cups. And if you see, this is called the Bush Schneider shell, where the anterior wall and posterior wall of the acetabulum are totally gone. There hardly any bone, and this has its wings. This has three wings: the one for the ilium, one for the ischium, and one for the pubic bone, where we can put in the screws and where the shell can sit. This is the augment we put with the shell. This is the rough anatomy where we have to care placement of the screws, where we have the shutting nerve. We have the shutting nerve in the obturator, superior gluteal, notch, and the inferior gluteal notch. The most important is the superior gluteal notch and the inferior superior gluteal notch. The sciatic nerve is there. We have to be very careful to define the nerve, and don't place any homens or or anything in the notch. Otherwise, you are bound to get damage the sciatic nerve. The other is you always look for the superior gluteal vessels. Superior gluteal vessels are very important for the abductor muscle vascularity. Otherwise, you will not gain much if you damage these superior gluteal vessels. These are the minimum anatomy. And then the obturator canal is there. Never put anything because the obturator nerve or artery or vein can be damaged. This is a very risky area where we have to be very careful. So it is like a dead end we are entering. Now coming to few cases, this is a young lady I did recently. This was done elsewhere, and they had put a dynamic hip screw fixation for the cervicotrochanteric fracture of the IT fracture of the uh, femur. And ultimately, if you see, the neck has foreshortened. There was a more than 2 centimeter shortening, around 1 inch shortening was there, and the head has collapsed, and there is avascular necrosis, and it has become sclerotic, and the screw of the dynamic screw of the implant is nudging against the acetabulum notch, the spirally, and causing damage. So after this thing, we were able to easily achieve. But if you see, the anatomy was totally disturbed and minded. The most difficult part is how to ream the medullary canal of the femur. It's a very tough thing because the bone is osteoporotic in most cases because of multiple surgeries or complex anatomy, and you are bound to puncture the medullary canal, the cortex, which can cause misplacement of the stem. How to solve this? We like in the femur nailing, we put intermedullary nails, guide wire, and then we ream it successfully. I mean consecutively under the C-arm guide. That takes a lot of time, because otherwise many times if the cortex get punctured, and the implant will be the stem, at the end of the stem, tip of the stem will be out. So it takes a lot of patience, it takes a lot of time, and you have to be very slow and very meticulous, and you have to check for the blood loss also, and any bleeders, you have to be very careful. So a lot of operation needs has to be done in such cases. It's not simple primary this thing. So this was another case where there was all damage to the patient came with old, uh, uh, I mean multiple uh, impla- primary hip failed primary hip with some uh, acetabular bone loss. There was no I mean no posterior wall, no anterior wall. The acetabular was wandering acetabulum, and the anatomy of the uh, stem femoral, uh, I mean, was also changed. So this is how we put the Bush Schneider cage. We have put the Bush Schneider cage, and where it has given stability both for the acetabular shell, and now if we see now how it stable it is. And these are certain things we look for in the X-ray whether it has been sitting. If you look, there is we look for the teardrop, and the teardrop is our guide for placement of the uh, proper placement of the uh, acetabular shell, and it helps to maintain the horizontal offset of the hip. We have two offsets, the vertical offset and the horizontal offset. Vertical offset helps in gaining the length of the limb. The horizontal offset helps to maintain the stability so that it doesn't dislocate. So there is a very good relation, I mean a very good ratio has to be maintained for the horizontal offset as well as the vertical offset of the hip. This is another case where the it was a fracture acetabulum, and patient uh, underwent this thing. We had to fix the fracture acetabulum, and it had opened up. There was a total opening of the diastasis of the acetabulum, but luckily it was mainly the posterior wall. The anterior wall was okay, so we were able to first put I mean the fix the acetabular wall with the help of the plate and screws. And once it was stable, then we placed the implants for the hip replacement. So it takes a lot of planning and lot of I mean one has to take all the tools in hand to go after these cases. These are not straightforward cases. A lot of experience has to be there put in. This is another case where we put the acetabular, I mean the Bush Schneider shell, and we were able to maintain the stability of the acetabulum, and then uh, we place the uh, hip. The hip can be in the Bush Schneider. We have both are available with the cemented cup or uncemented. Both are available, and prefer to go for uncemented cups because their longevity is more. Whereas even in old patients, say 70 plus, even cemented cups are fairly good to give them a life lease of another 15 years or so. See, this is especially osteochondroma formation. Ost- Osteochondromas are formed. It was bilateral, and so this is also not a simple case. In this, why it is not simple case? Because you have to look for the nerves, you have to look for the vessels, and they have to be taken care so that while removing first shaving off these osteochondromas, you don't damage the vascularity or the nerves. You still need 3Ds, 3D CT scan, or even MRI to find out the whether the vessel or the nerve is not engulfed in between. So this was all we were able to maintain it once it was able to clean it. This was with the help of the complex. I mean, although we call it complex primary, but it is THR, but it is complex primary because we were able to achieve with the primary hip implants. This is another case of fractured neck of femur where if you see patient was young and it was fixed with the help of CC's cancellous screws, multiple cancellous screw fixation. However, the fracture did not unite and it became loose and the implants were loose and the neck has foreshortened and luckily the although the avascular changes are not there at present much, but the hip was painful. So the the anatomy is always altered because the version is changed. The version is changed. We went for the cemented uh, hip because of some low budget patient problem. Because cemented hips are comparatively low budgeted as compared to the uncemented hips. This is another, if you see, there is total diastasis of the acetabulum. Total, it has opened up. The anterior wall and the posterior wall of the acetabulum is totally opened up, and there is some uh, cartilage or uh, damage in the osteochondral damage of the femoral head. This is how we were able to manage it, and we got it I mean stability of the acetabulum with the help of the push Schneider uh, shell, and then we were able to achieve the total hip replacement. This is another case, an old case where the patient was operated for the fracture, central fracture dislocation of the hip elsewhere. However, over the time, the head became avascular and it collapsed. And if you see, the femur has migrated proximally, cranially, and there is external rotation. Seeing the lesser trochanter, there is external. It is fixed in external rotation. So these are complex because you see all the disturbed anatomy. You look for the sciatic nerve first, and the good thing is never go for mini incisions. Go for extensive incisions. And in the hips where you have to construct the acetabulum, I prefer the posterior approach. Posterior approach are two types. One is the Austin Moore approach or the Langenbeck, Cocker Langenbeck or Southern approach. Moore's approach or Langenbeck. There is a difference in the uh, Cocker Langenbeck approach or Southern approach. The sciatic nerve is first defined, and the acetabulum is widely visible. So reconstruction of the acetabulum is always easier. Austin Moore is only for primary where we need to do hemiorthoplasty or primary hip arthroplasty. So you have to define it. And primary hip one can do by the anterior approach of the hip or where we have the Smith-Peterson approach or the anterior approach, or we can have the anterior lateral approach or the Harding's approach. These are good for primary hip, but in case of these where we have to reconstruct the acetabulum, always look for the sciatic nerve, and the best approach remains the Langenbeck, Cocker Langenbeck, or Southern approach, where we go for the define the sciatic nerve, which is always between the two heads of the gemini and uh, the per- piriformis tendon is our guide. We start with the location of the piriformis tendon. We do take it up to the origin from the uh, ischium, and then we follow the rest of the external rotators. This is another similar case where the acetabulum was totally damaged and it was again fixed with the acetabulum. We were able to achieve with the plate and screw and with the stability we were able to do with the primary hip. Thank you. Now I would like to have some questions. Any
Yeah,
any queries?
thank
You're
you,
welcome.
thank you, Dr. Rakesh. Uh, I request the participants that you may have a lot of questions around what Dr. Mahajan discussed or about hip replacement overall. Dr. Kayumba, I think you are specializing uh, in this stream itself. Do you have any questions? You can ask your questions directly or you can type them in the chat. Dr. Rakesh, one general question that come up is the financial implication of hip replacement surgeries. Like
Yes.
as most of the African countries are also developing like India, and most of them
Right.
don't have insurance. So, what is the financial aspect of it?
See, the thing is, earlier the international company Johnson, Stryker, and Zimmer were providing us with all the revision hip replacement or these complex hip replacement implants. But now, unluckily, they have withdrawn most of their hardware because of some duties or something because of government policies. But luckily, presently, we are using all the. We have two, three Indian companies which have come up very well. They have collaborated with these companies, and they have come with a cost-effective methods. And earlier, it used to be costing like some $10,000 or $12,000 hip replacement. Now that cost has come to, I would say, 7,000 to 8,000, between 7,000 to 8,000. And we try to, in case there is some problems, we try to reduce our surgical fees. I'm definitely one person. I always try to help the patient to the maximum. I tell them I reduce my fee, and I'm ready to help the patient out.
Sir, another question that they face is that every country in Africa, the uh, the healthcare infrastructure is at different levels. So when should, like most of the doctors who are practicing in Africa, what should be the trigger or what should be the sign when they feel that this one thing is very obvious that it's a candidate for replacement, hip replacement, but there might be other areas that you handle where it might be indicative to them that this patient may require help abroad, and maybe we can discuss this with Dr. Rakesh or write a note and share it with Dr. Rakesh that if this is a fit case for international referral. So that's a dilemma that day-to-day doctors face.
Yes, my WhatsApp number is always there, and I try to work up as much early as possible. Whenever the doctors, they can send their patient brief history, and they can send their minimum X-rays. I can guide them what would be the best option for them, and rough stay and rough expenses. That is the easiest way to. And the other is through the geo companies, and the interaction will be there. And I think repeat we can on this platform we can discuss these x-rays or any indication for the surgery, whether surgery will be helpful or no, and what will be the total expenses or what will be the stay. This is a very good platform where we can discuss the we can carry on like say once a month or once in 2 months, and you can have the x-rays or the reports of the patients, and we can discuss it.
Okay, so sir, many times would it be helpful, like if we dedicate one session once in a month or one session once in 2 months around orthopedic cases with you, where they share their reports in advance? Uh, I think we have Dr. Rakesh. I think we have lost Dr. Rakesh. Let's wait for him to rejoin. Uh, Everyone, please bear with us. Meanwhile, Dr. Dinawal has shared a question. Uh, Please, if rest of you have any questions, you can ask. I'm checking. Uh, sir has joined back.
Sorry. Sorry. The laptop
I,
popped up. Sorry.
yeah, so
Sorry.
we have it's okay, sir. We have a few questions.
Yes.
One question is from Dr. Dinaol. He practices in Ethiopia.
Right.
His question is first thanking you for sharing your experience. And question is, sir, what is the success rate after operating athletes and resuming their profession in hip replacement surgery? After hip replacement, how early can athletes resume their training and sports?
Right. See, it depends on the pathology, and it depends on the, athlete activity. I mean, if they're long distance runner or this, then we have to go for different type of hip replacements. Just like Andy Murray, Andy Murray, I think the tennis player, he had a hip replacement, and one cannot be 100% this thing, but he can carry on with most of his activities for the athletes, right?
Okay.
Right.
Sir, what about a case in a physically demanding sport like football or basketball where there will be a lot of jump involved and a lot of hip?
Uh, uh,
Can they
hip,
have a
hip
career? Hip.
I agree. See, it depends. See, sports persons or these people, if they have a total hip replacement, then these are not the sports one can carry on. But they can change the sport. That is the best way,
Okay.
right?
So
That
now,
is the best way. So if it only say if it is a it was a condition called FAI, where there is femoroacetabular impingement, where we do the hip arthroscopy, we remove the impingement, we clean the cartilage, and we put the stem cell therapy. This is the other thing. We put stem cell therapy and let the hip regenerate, say by 6 months, and we get the repeat MRI done and see what we see wonderful results there also. This is the other option.
okay, sir, interestingly, like in cricket also, like we have seen in the subcontinent, fast bowlers, Indian or Pakistan, like we have so much media reports, like Wasim Akram underwent so many injuries,
Right, right,
Zaid Khan from India, and fast
right.
bowling is again very demanding, run up, jump. So
Mhm.
how do they come back to international sport after very demanding surgery, sir?
I definitely see most of the sport activity damages ligaments
Okay,
or osteochondral defects. They they don't have arthritis. Hip arthritis is a different issue.
okay,
Hip replacement, the arthritis is the culprit, where there is no cartilage, the anatomy is totally deformed, and patient is not able to carry his daily routine activities.
okay, understood, sir.
And after hip replacement, you carry your daily routine activities, you feel happy.
Okay,
Pain-free hip gives you so much satisfaction. Whereas sports activities is different, mainly damage to the part of the cartilage, one or damage to the ligament. Where we correct those, we have different, different techniques. One is the PRP injections, one is the stem cell therapies. They are very good, and plus various different orthoscopic procedures. They help to repair those ligament injuries. That's why after 6 months or so, they are back to their high class sport activity.
okay. So we have another question. The doctor has not written the name on the screen. This is
Right.
device name, Galaxy. So in patients with advanced osteoarthritis of the hip joint who present with pain but sufficient mobility. So pain is there, but mobility is sufficient. Is there a place for conservative treatment management? And when should they recommend surgery?
See, we do the basic investigation. We see on the X-ray whether the hip joint space is maintained. One thing means pain has started, but mobility is there because the hip space is there. The cartilage is maintained. That way, you don't straight away advise hip replacement. We have other options. That's what I'm saying. We have the arthroscopic method where we clean up the osteochondral extra bone formation or part of the cartilage which is damaged, and we repair it with the help of stem cell therapy. That will be a good indication instead of going for hip replacement. Once the cartilage on the CT or MRI is completely damaged, there is no vascularity. I mean, there is no blood flow to the femoral head. Then the only answer is hip replacement.
Okay. So we have a question from Dr. Stephen Kope. He's from Cameroon. First,
Right.
thanking you. And then, sir, his question is, do you have an expertise in hip arthroplasty for children with sickle cell disease? So I think so the question
Right.
is two-part. One, for sickle cell disease, Dr. Stephen, Dr. Mahajan's colleague, Dr. Dharma Chaudhary is another, like, his is a center of excellence
Right. Right.
in orthopedics,
Right. Ah,
BLK-Max. There's another
ah.
center of excellence for bone marrow transplant, which is the standard treatment for sickle cell disease. And the best results are when it is done early, when the patient is still a child. Now, the other question is, sir, I mean, hip replacement, hip arthroplasty or replacement for children, is it anyone recommended? Like there are
No.
multiple thoughts.
Ah,
The
right. Right.
skeleton does not
See,
develop.
hip arthroplasty is not recommended below 18 years of age. 17, 18, below 17, 18 years, hip arthroplasty is not recommended. We have the arthroscopy method where we clean up the damage, or where we have the osteotomies. We change the bearing surface of the hip. We have the valgus osteotomy, varus osteotomy, different geometrical osteotomies. We see on the MRI where is the main damage, and we change the weight bearing area of the hip ball, and the pain is relieved much better. Hip is not recommended. Hip replacement is not recommended below 17, 18 years.
Right.
We have to wait.
So there is a question from Dr. Andrew Ordney. First, there's a thanks to you from doctor who asked about orthoarthritis and conservative treatment versus surgery. And now the question from Dr. Andrew is, how can patients generally expect their hip implants to last, and what factors influence the longevity of these implants?
Mm. So there are certain, after hip replacement, there are certain conditions which are not recommended. Floor, Sitting on the floor, sitting cross-legged on the floor, or as sitting with I mean, with the cross-legged is not allowed. Sitting on the squatting is not allowed. These positions of the body can damage to the implants, cause loosening of the implants, and avoid I mean high sport activity. I mean those means high energy activities, sports activity are to be.
So
They will increase the longevity up to 35 years.
okay. So there's a question from Dr. William Gadaga.
Yes.
Okay, sir, with the longevity, I mean, if the patient follows the recommendation,
Yeah.
generally hip replacement candidates are people of the older age profile. So typically, once done, it will last the normal
For
lifespan.
yeah, more than 30 years.
So most will not need it again in life if they.
Yes, 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 yes. If well fit hip lasts for 30 to 35 years.
Okay, sir. So there's a question from Dr. William Gadaga. Dr. William Gadaga is from Harare, Zimbabwe.
Right.
His question is, maybe you mentioned it, he missed it. He want you to briefly describe how stem cell therapy is used in hip disorders. You touched
Yes.
upon this in
Ah,
respect to sports injuries also, sir. But maybe if you can
okay.
a little bit
So,
more.
so stem cell. So, what is the role of stem cell? Stem cell are osteoprogenitor cells or osteopotent cells which can convert into the thing you want, either osteoblast or chondroblast. So here we are dealing with the hip cartilage. So we have say few islands of the hip cartilage which are damaged. We clean up that with the hip arthroscopy and we inject the stem cells. Over the time, the if we review with the MRI, we see excellent changes. I mean, just like grass growing, the cartilage also starts growing and it shows less damage areas. And over 6 months or so, the patient has less symptoms. It does take time, stem cell, but because they are the basic cells. which can get converted into the chondroblast, and the cartilage starts growing.
Okay. So anybody, do you have any other question? Any patient case that you may want to discuss, even if like they are not an international referral patient, just for your guidance? And as Dr. Rakesh said, that if you face any patient, if you need any clarification around management of any case, please feel free to write a doctor's note. Sir, we have a work group, a WhatsApp work group individually with all the doctors. Whenever
Right.
they need any clarity around, so they can, and they have a relationship manager assigned to them. So whenever you have either you want to discuss a patient case or you want some clarification, please feel free to share it on your work group, and we'll make sure that through Dr. Rakesh's team, we'll share it with him and we'll get you the right note of guidance. If your note is specific, the guidance will be more specific. We have Dr. Gadaga again question. So generally, Dr. Gadaga asks, generally, how are these stem cells harvested and how long does it take to harvest them?
In orthopedics, we harvest it from the iliac crest, and it needs around more than 120 ml of blood. We use a white bore needle, and we put in the iliac bone. It can be PISS, posterior iliac spine, or anterior iliac spine. And from the marrow of the iliac bone, we harvest around 120 ml of blood, and then we put in the centrifuge machine. It takes around 45 minutes to 1 hour to, centrifuge, and then we have the stem cells concentrate, and then we inject.
So anybody has any follow-up question? Dr. Michelle, Dr. Cornelius, Dr. Solomon, Dr. Hivat, Dr. Kayumba, Dr. Reshitu, Dr. Stephen, I hope your question around hip replacement in a sickle cell patient of children was answered satisfactorily. So, to extend, like as you said before 17 or 18, because the skeleton has not developed, has not matured, hip replacement is generally not recommended. Uh, but also, sir, if there is a adult sickle cell patient where
Yes.
they have passed the age of bone marrow transplant intervention and
Mhm.
they are a candidate for hip replacement, so
Yes.
how do you manage it, sir?
What happens in sickle cell? We have avascular necrosis of the femoral head. The blood supply to the femoral head is damaged, and now the head starts getting dead, and it goes into hip arthritis. So most of the cases, after discussing with Dr. Dharma, once the sickle cell level in the blood is less than 20%, patient is fit for surgery. So we plan the surgery, and but most of the cases, the primary hip arthroplasty is done.
Okay, sir. So I think, sir, we have the masterclass time is also finished. If somebody has any question, please ask. I think if you have a question, sir can extend the session for a few minutes to answer it. But if you have any question in future also, whether it is around managing a patient case, whether it is around any clarification, many times, like while we are building Jivo, there are so many problems we work on. I don't hesitate to ask. I don't hesitate to ask somebody who knows more than me about AI or product. So we all have doubts. So please don't hesitate. Write a specific doctor's note. We'll share it with Dr. Rakesh, and within a reasonable time frame, get you a response. So thank you, Dr. Rakesh. Thanks a
Thank
lot, sir.
you.
So it
Thank
will
you.
mean a lot because as a doctor, you are aware about the patient life cycle. Surgery is one intervention, and here we have mission committed doctors who are attending this. If you can
Right.
just say a couple of lines around how doctor to doctor collaboration across borders, the dialogue and collaboration, how that is a better alternative to international referrals and patient management than just a commercially driven, agent-led medical travel, sir.
Uh, I welcome all the doctors taking Sunday evening, and it has been a good interaction session. And I hope to carry on with the help of Varun many such sessions. And our aim should be make the patient happy and pain free. See, definitely, medicine has become commercialized a lot, but I feel more dedication. See, commercialization is a different issue, but I try to give the best, and I hope with your efforts and with your blessings, we can carry on this platform for a long, long time and achieve maximum success.
Thank you, sir. It is just like they say, sir, it's just a very small start, but as
No,
doctors
but it is an
participate,
excellent start. I would say it's an excellent start.
but as doctors from across the borders participate, they can, change. Like, so we did one experiment where we had cancer and chemo patients who came in under Dr. Dharma's care,
Mm.
and long treatment, even staying in India for months is problematic. But we
Right.
worked with Dr. Dharma there because there was another doctor. I mean, a Jivo
Mhm.
doctor-doctor platform. There was another doctor in the patient's home country. Dr. Dharma tried a few cycles. Patient responded well. Wrote, sorry, not Dr. Dharma, Dr. Chandra. So
Right.
wrote the protocol. Patient could
Mhm.
buy those drugs from India and carry the therapy in the
Right.
home country. And with the
Mhm.
doctor's involvement, we could do that 6 monthly review how patient is responding. So,
Mhm.
uh,
Definitely, we can do such kind of exercise also. There are certain things we can guide, but certain complex surgeries we have to carry on. But basic, we can guide them, and that will be a good platform to guide them also, so that certain activities can be carried on there in their hometowns.
yes, sir. Thank you, sir. Thanks a lot for your time. And thank you, everyone, for taking time out on a Sunday evening and attending this masterclass. Thank you, everyone.
Right. Good night.
Thank you.
Okay. Good night.